Thank you. Thank you again for the kind invitation by Luca Generali and Edgar Mocano. It's my pleasure to be part of this webinar series. Today, I would like to discuss with you in the next 35 minutes pre-IVF progesterone use. It's a wide, broad title for this to discuss actually. I will try to do my best. I wish you a very fruitful and influential webinar. There is no conflict of interest associated with this presentation. Since progesterone can be used for several aspects, various aspects before IVF, I prepared an agenda as follows. First, I would like to discuss with you the progesterone use for follicle synchronization and progesterone use for scheduling IVF cycle. And then I will discuss the progesterone use to induce the withdrawal bleeding in anovulatory cases. And also I will discuss the progesterone use for the treatment of endometrial pathologies and move forward with the treatment of endometriosis before IVF. Actually, I am not sure that progesterone prime stimulation is under the topic of this title, but I know the webinar series, upcoming presentations, and it's not covered by the other presentation. After the internal discussion, we decide to present here the progesterone prime ovarian stimulation. As a clinician, every day we encountered a patient on the first day of stimulation with a growing follicle higher than 9 millimeter in diameter. When we start ovarian stimulation, it ends up with the asynchrony up to 50% in the cycle. Actually, this reduced the efficacy of ovarian stimulation. Several decades ago, some publications try to do pre-treatment to reduce the number of asynchrony in ovarian stimulation cycle to maximize the efficacy of the treatment. Estrogen, progesterone, and combined estrogen and progesterone pills are used for this purpose. Also, GnRH antagonists have been used, aim to reduce FSH and LH, starting a standard cohort, synchronized cohort, end up with a good response. Actually, few publications available up to date in the literature for such an important topic. 4 small sized RCTs compared the reproductive outcome and the stimulation performance. A recent cohort published in 2017 when compared the number of oocytes retrieved across the different protocols. The number of oocytes retrieved were similar between the treatment and no treatment group. Testosterone, norepinephrine is the main progesterone used for this purpose actually during the progesterone pre-treatment in these 4 studies. When we compare reproductive outcome, higher clinical pregnancy rate were reported. However, when we compared live birth rate, only 2 studies with small sample size reported no difference. Only advantages of using progesterone for pre-treatment starting from the mid-cycle of IVF cycle, previous cycle, in mid-cycle of previous cycle before the ovarian stimulation cycle, actually reduced the cyst formation at the beginning of the cycle. Based on the low quality data and small sample size data, recent ovarian stimulation guidelines do not recommend routinely use of progesterone to increase the efficacy of ovarian stimulation cycle. Actually, they acknowledge the use of progesterone not only for the synchronization but also scheduling purposes of the cycle, and they suggest as a general practice point it's acceptable to use progesterone for the purpose of cycle scheduling. I should like to take your attention the use of OCP for pre-treatment. Actually, also they include the progesterone. If you use OCP more than 10 days, according to the literature, between 12 days to 25 days, it's associated with significantly lower live birth rate, according to 6 randomized trials, including more than 1,000 patients. So please be careful with the use of progesterone. I should acknowledge that the included studies did not take into account and heterogeneous in terms of washout period between the cessation of the OCP and starting day of the stimulation. What about the scheduling of our cycle? As a clinician and actually the laboratory person, we sometimes need to adjust the workload according to laboratory, our laboratory personnel number and also the equipment number. So scheduling is a really important point. In Europe, we all know that most of the clinics are using progesterone for scheduling, but unfortunately, not too many studies available published in the literature. I would like to discuss with you the recently published Fischl protocol. Dr. Robert Fischl from Hamburg provide his protocol is a publication and recommend to use norepinephrine starting around the cycle day 20 and use it for 7 to 14 days and recommend to stop it 5 days before the ovarian stimulation. Ovarian stimulation started, they should be adjusted and it should be planned to start on Friday, Saturday and Monday to end up with the egg retrieval during the weekdays. By this way, you can schedule your workload also, you can avoid the weekend and holidays egg retrieval procedures. Actually, this protocol has been validated by the other different setup in Brazil with the Dr. Esteves clinics, and they compared the result and across the different age, they reported the almost identical reproductive outcomes, namely using progesterone for pretreatment without jeopardizing the reproductive outcome may have benefit for scheduling our oocyte pickup day. Another point for progesterone is before IVF to induce the withdrawal bleeding in oligoanovulatory patients. These patients are most likely PCOS patients, and unfortunately not too many studies dealing with this question. I would like to discuss with you the only study. This is the secondary analysis of the study published in 2016 in New England Journal of Medicine, which is comparing fresh and frozen embryo transfer in PCOS patients. Actually, the menstruation induction is not randomized. In the secondary analysis, only the clinician preferences was the reason for the groups, and combined oral contraceptive pills was used in the vast majority of the cases, and micronized progesterone or dydrogesterone was used 1/5 of the cases, and control group served as a spontaneous menses group. When we compared the fresh transfer cycle for those three groups, actually oral contraceptive groups associated with significantly lower estradiol level, significantly lower LH level on the trigger, and significantly lower endometrial thickness. Regarding the reproductive outcome in fresh or frozen embryo transfer, oral contraceptive pills as an inducer for menstruation is significantly associated with significantly lower ongoing live birth rate when compared with the control group, and also in frozen total embryo cycle is associated with significantly higher pregnancy loss rate and lower live birth rate. There was no difference between the control group and the progesterone treated group. Actually, despite the potential risk of selection bias on this study, we may say that progesterone used for withdrawal bleeding yield high rates of live birth rate when combined with the combined oral contraceptive pills. Progesterone can be used also treating endometrial pathologies prior to IVF. The most commonly encountered pathology related with the endometrium during the IVF treatment is endometrial hyperplasia. This Cochrane review compared the treatment outcome with levonorgestrel IUD versus non-intrauterine progesterone, and non-levonorgestrel IUD regression rate was significantly higher with the levonorgestrel IUD group when compared with non-intrauterine progesterone group. In non-intrauterine progesterone group, regression results around 72% rate, while it was around 85 to 92% in levonorgestrel IUD group. What about the early stage of endometrial cancer? We need to treat those patients as in a fertility preservation manner to move forward with the IVF. Actually, in those cases, the performance of levonorgestrel IUD is well. It's around 63% regression rate, and also we should keep in mind that the relapse and recurrence is around 30% within 2-year follow-up period with the treatment of levonorgestrel IUD for the early stage of endometrial cancer. Once we reach the complete response, namely after 6 to 12 months, there is no residual disease with the sampling. It means that complete response. If we could achieve the complete response, it's associated with good reproductive outcome, regardless of the treatment, how you achieve the complete response. The pregnancy rate reported around 40 to 60%, and 80% of those cases could get pregnant, end up with the live birth rate. The important point for those cases during the follow-up, sampling seems to be, according to recent meta-analysis, should be via hysteroscopy, because hysteroscopic sampling for the follow-up is associated with significantly higher pregnancy rate, lower miscarriage rate, and higher live birth rate when compared with the dilatation and curettage. It means that dilatation and curettage made a traumatic effect on the basal endometrium, compromising the implantation in the upcoming IVF cycle. The interesting thing is that the polyp is most commonly encountered in infertile group of patients, but it's only associated with around 1% of the cancer risk. It can spontaneously resolve during the follow-up period. It's around 25%. The gold standard for treatment and the diagnosis is the hysteroscopy. I would like to take your attention for the only first article dealing with the treatment of polyps with sub-Q progesterone administration during the luteal phase for 3 months. It's associated with the significantly higher regression rate when compared with the standard no treatment follow-up. I do not mean here we should treat all the polyps with the progesterone, but I'd like to take your attention that progesterone might be used for this purpose. Progesterone for treating endometriosis prior to IVF is another debatable topic. Actually, we all know that progesterone can be treated with, endometriosis can be treated with progesterone, and it's efficient for the endometriosis associated pain. Several progesterone type has been used previously, and almost all of them is efficient to reduce the endometriosis associated pain. The question is, as we all know, during the IVF cycle, long suppression might be related with favorable outcome in IVF. Actually, the recent Cochrane refused this hypothesis. But the question, if we if we suppress the disease for 2 to 3 months before IVF with progesterone, would it be beneficial for our cases? Available 5 studies is pulled in a recent meta-analysis. 3 of them are cohort study, 2 of them are randomized trial, including more than 500 cases. Overall, there is no differences in live birth rate when we compare Dynogest treatment with non-Dynogest treatment. Dynogest treatment actually. However, when we look at the subgroup comparisons, Dynogest treatment is associated with significantly higher live birth rate when compared with the no treatment patients, but it's associated with lower pregnancy rate when compared with the long agonist protocol. Similar outcome was yielded with the treatment of Dynogest and dydrogesterone group. Overall, this quality of the data is very low, but the live birth rate following Dynogest treatment might be significantly higher than observed when compared with non-treatment group, and we need further evidence to make firm conclusion on this point. Also, different progestins should be tested for this attempt. The hot topic related with the progesterone use during IVF is the progesterone primed ovarian stimulation protocol. First baby was born with natural cycle in 1978, and during the first decade of IVF, we used HMG only protocol without pituitary suppression. And the second and third decade, GnRH agonist was the dominant protocol for pituitary suppression, and during the mid-third decade and fourth decade, antagonist protocol, because of the safety advantages, become the predominant protocol for the pituitary suppression. We first met with progesterone primed ovarian stimulation in 2015. The first report was infertility sterility in that year. The advantages of PPS protocol is lower cost, fever medication, and permit us GnRH agonist triggering to avoid from OHHS. Disadvantages is due to the detrimental effect on endometrium. Only frozen embryo transfer is an option. We could not move forward with the fresh embryo transfer. From old studies, we know that high progesterone can block a late surge. But we actually did not understood clearly yet how progesterone is working in HPO axis. Progesterone priming seems that slow the pulse frequency and pulse amplitude, and then reduce the plasma concentration if we use during the ovarian stimulation. Previous pharmacokinetic, dynamic, and pharmacological studies showed that all progestin have in common the so-called progestogenic effect, and ovulation inhibition dose was defined from the pharmacological studies. But when we look at the real life data and recent publication, different types, different doses of progestin have been used to block a late surge. And when I summarized all the data from 4 randomized trials and 2 retrospective trials in this table, it's briefly I can say that 20 milligram dydrogesterone is equivalent to 4 to 10 milligram medroxyprogesterone acetate, and it's equivalent to 100 to 20 milligram micronized progesterone in terms of LH suppression. This is the first study that we met with progesterone prime ovarian stimulation protocol, comparing the medroxyprogesterone acetate twice daily with short agonist protocol. And of the included 150 patients, only one ended up with the premature LH surge. And regarding reproductive outcome, cumulative pregnancy rate per woman were similar between those group. All patients underwent a freeze-all cycle and frozen embryo transfer was performed. Following this trial, several publications have been made. A recent systematic review, very nicely prepared, compared the PPS protocol with GnRH antagonist 1. Of the included 10 studies, 3 of them were randomized trial. Total gonadotropin dose consumption were similar between progestin and antagonist group, and number of oocyte retrieval again were similar across the studies. The sensitivity analysis comparing the different group of patients, including the PCOS patients and diminished ovarian reserve patients, yielded similar and comparable results. When we compared PPS with agonist protocol, 6 studies were included to the systematic review. 2 are RCTs. Of the included 6 studies, 2 of them is long agonist protocol, 4 of them is short protocol. When we compare total gonadotropin dose, you can see in the first graph a huge variation between the groups, because some of the paper are short agonists and some of them are long agonists. Overall, number of oocyte retrieval and total gonadotropin dose consumption were similar. When we compare the long protocol with PPS, lower gonadotropin consumption was made in the PPS protocol, and the number of oocyte retrieval was similar. Interestingly, the PPS protocol might be flexible, like GnRH antagonist flexible protocol. Rather than starting progesterone on the first day of stimulation, we may start the progestin at the 6th to 7th day of stimulation, when the follicle reach around 12 to 14 millimeter in diameter. This is very likely to a flexible GnRH antagonist protocol. All the studies comparing this protocol, efficacy of this protocol coming from Turkey. The first study was made in normal ovarian reserve patients in donation cycles. Flexible protocols are comparable with GnRH antagonist protocol. We know for premature LH surge, diminished ovarian reserve patients are much more vulnerable. When made a comparison for flexible PPS and antagonists in the diminished ovarian reserve patients, the results again were similar. Also, PPS were compared with flexible PPS with the standard PPS, fixed PPS. Again, the results were comparable, but all the studies are retrospective design, and also the sample size is low. Why the flexible PPS is important? Because as a clinician, we don't have to make a freeze-all decision on the beginning of the cycle. We may make our decision based on the patient response on the mid-cycle, because some patients unexpectedly will respond higher to ovarian stimulation and we may change our mind from fresh transfer to freeze-all cycle, and we can reduce the cost by using flexible PPS protocol. Another protocol is random start PPS protocol. This is tested only in this study. We need further studies, of course. This is the fertility preservation setting, included patients with breast cancer and hematological cancers. Of the included, 86% were compared in terms of protocol used. In the random start PPS protocol, regardless of the day of cycle, progesterone and gonadotropin started simultaneously the same day. And when we compared the results, the HMG dose used were similar, maturation rate were similar, and also fertilization rate were similar, rates were similar, good blastocyst rate were similar. But of course, we need to replicate the result by the other groups and with the larger sample size. The question is whether PPS has any detrimental effect on oocyte competence. Actually, based on the available data, only one is RCT. Most of the studies are retrospective trials, but PPS likely does not have and compromised oocyte competence when compared with GnRH antagonists. Vast majority of the studies reported a similar fertilization rate, similar blastulation rate. Only one study reported lower blastulation rate, but with the high risk of type 1 error, and one study reported lower good quality blastocyst. Two studies reported, but actually the same data reported lower good quality blastocyst rate with use of PPS. Any effect of PPS on euploidy rate in different 4 studies. These were tested in Italy, H-match control group in PGTA setting, when compared the result, similar euploidy rate. In China 2 study, particularly the study by Yang et al. Compared the euploidy rate and stratifying by age and reported similar euploidy rate. The recent one included only patients with advanced maternal age undergoing PGTA, and similar euploidy rates were reported. But conflicting data exists. However, this data has major limitation because of the conflicting data published in 4 studies. Of those 4 studies, 1 reported lower euploidy rate, and 3 studies reported lower cumulative live birth rate with the use of PPS. But as I said, these studies are non-randomized, mostly case-control studies. Only 1 propensity match control studies, and suspiciable high risk of selection bias. The first one, which is the propensity match control study, trying to report cumulative live birth rate, actually did not use the standard definition of IGMART glossary for the cumulative live birth rate, and use the time frame to define the cumulative live birth rate. And when we look at in detail, a higher number of embryos awaiting for the transfer in the TPS arm, which makes, the comparison for the cumulative live birth is invalid. Only 1 study reported higher euploidy rate, higher aneuploidy rate in the PPS treated group actually, but the sample size is very low, 34 patients, only PPS arm. And I should stress that aneuploidy rate reported in the study was significantly lower, actually not when compared with the standard literature, questioning the validity of the genetic platform and PGTA lab. The other 2 studies are published by the same authors and by the same groups. Actually, they used almost the same data by adding the other groups in 2 different journals. The problem with the studies, they include the PGTA-M and PGTA-SR studies. Although the mean age were comparable, age-certified comparison were not available in the study in the result session. So these are again the case control study, which make a high risk of selection bias. Considering the limitation of the few conflicting studies, it seems that highly likely that PCS does not have any detrimental impact on oocyte competence or euploidy rates. When we look at the perinatal and neonatal outcome, few studies are available. This is the larger sample size one, reported similar perinatal and neonatal outcome. Regarding congenital malformation, a recent systematic review meta-analysis including more than 10,000 live births treated with progesterone-primed ovarian stimulation did not find any association between the PPS and congenital malformation. Progesterone-primed ovarian stimulation is cost-effective in freeze-all cycles because you don't, if you already decide to freeze all, it's cheaper than the other pituitary suppressors, and also you need fever monitorization during the ovarian stimulation follow-up, and which means indirect reduction of the cost for center and for the patients. Recent publication compared in a fertility preservation setting the cost effectiveness of GnRH antagonist and PPS. As you can see, PPS is cost effective. Freeze-all approach gaining popularity over the last decade. The main contributor for the increase in freeze-all approach is the increasing number of PGTA cycles all around the world. Actually, the freeze-all approach can be divided to two groups, the elective freeze-all or non-elective freeze-all. Elective group include PGTA, dual stimulation, the patients with endometriosis and adenomyosis, patients and doctor's perspective. Non-elective group, high risk of OHHS, late follicular phase progesterone elevation, which is associated with detrimental reproductive outcome, embryological or uterine or tubal reason, which did not allow clinician to make fresh embryo transfer. Is freeze-all all for all? Actually, several randomized trials in different patient population has been published over the last decade. But based on this randomized trial, recent cohort meta-analysis clearly showed that dividing the studies according to day of embryo transfer, cleavage stage or blastocyst stage transfer, overall no difference in cumulative live birth rate in freeze-all or conventional IVF cycle. Obviously, freeze-all is not for all, but there is a heterogeneity between the studies associated with the included study population. We acknowledge this, and since this heterogeneity exists between randomized trial, efforts to identify individuals who would benefit most from the freeze-all approach is ongoing. This is the individual patient data meta-analysis protocol published in BMG Open last year. We are awaiting for the results of this meta-analysis to identify the patients who would get most benefit from the freeze-all approach. Based on the available data, to whom we should consider PPS, actually all patients who is the candidate for freeze-all approach can be, for PPS might be the first choice of protocol. These are the donor stimulation patients, fertility preservation patients, and PGTM and A cycles, also those stimulations, and the patients who are under the risk of high OHHS risk should be the candidate for PPS protocol. To conclude, for such a wide topic, routine use of progesterone for follicle synchronization is not recommended according to low quality data. Progesterone may help us as a clinician for scheduling the ovarian stimulation cycle and avoid from the holidays and weekend egg retrieval and adjust the workload on the laboratory part. Progesterone might be the first option for inducing withdrawal bleeding. Only secondary analysis of the one study, it's associated with higher live birth rate when compared with the OCP. Levonorgestrel IUD should be the first choice for treating endometrial hyperplasia and early stage cancer prior to IVF. And also hysteroscopic examination during follow-up should be the recommended one when compared with the dilatation and curettage, because dilatation is curettage associated with compromised implantation rates. Low quality data suggests treatment of endometriosis with progestin 2 to 3 months may improve the live birth rate when compared with no treatment, but obviously we need further studies, well-designed further studies. Regarding the PPS protocol, it effectively prevents premature LH surge and also yields similar number of oocyte and M2 oocyte. The flexible PPS and the random start PPS are new protocols and appear to be feasible. However, we need further studies to validate their effectiveness. Based on the local data, PPS does not compromise all-site competence. However, the data is coming from the retrospective studies. Still, randomized are needed in this context of PGT. Similar perinatal and neonatal outcomes were reported when compared with antagonist protocol. PPS is a cost-effective suppression protocol in freeze-all cycle compared to generic antagonist. I would like to thank you all for your attention. I would be happy to answer if you have a question.